Welcome to the Merit Education Rounds. To those of you who don't know me, my name is Dr. Elif Bilgic, and I'm an education scientist in pediatrics and Merit. So the Merit program is an education services program in the Faculty of Health Sciences dedicated to supporting Faculty of Health Sciences schools, departments, and programs in advancing health professions education scholarship with a vision to grow a community of scientists and clinicians to advance health professions education through research and applied science. Although today's Grand Rounds is virtual, many of us in this event are connected by the land on which we work. So I take this time to recognize that McMaster University is on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the Dish with One Spoon Wampum Belt. The wampum uses the symbolism of a dish to represent the territory, and one spoon to represent that the people are to share the resources of the land and only take what they need. Now, before leaving the stage to our esteemed guest today, I will provide a very brief introduction. So the title of today's Grand Rounds is Virtual Teaching in Health Professions Education. And we have Doctors Ruth Chen, Amanda Bell, and Ilana Bear. Dr. Bell is an associate clinical professor in the Department of Family Medicine and the regional assistant dean of the Niagara Regional Campus. Dr. Chen is an associate professor in the School of Nursing and the assistant dean of Program for Faculty Development in the Faculty of Health Sciences. And Dr. Bear is an assistant professor in the Department of Pathology and Molecular Medicine and the director for Learning Technologies Lab in the Faculty of Health Sciences. Now, they will share their experiences with virtual teaching and how they evolved and adapted their teaching approaches during the COVID pandemic. As a reminder, during the rounds, feel free to use the chat for comments and questions, and I will ask those during the Q&A period, but you're also, of course, allowed to use the hand-raising function and ask your questions directly. So without further ado, Drs. Chen, Bell, and Bear, the floor is yours.
Thank you, Ella, and thanks everyone for joining today. This session was really fun to plan because it gave the three of us, Ilana, Amanda, and me, who you see on your screen, an opportunity to connect on a topic where we each have experience with virtual teaching and learning, and yet we're also connected to different schools and courses in the undergrad and grad programs across the FHS. So these rounds allowed us to share our diverse experiences with you, as well as to tie these experiences back to applications that hopefully you can take into your own practice. So our session today will be broken down, and hopefully you can see this with the spotlight on. It'll be broken down into three main sections. In the first half of the section, right up there, we'll share our experiences with virtual teaching, and also included in this will be Amanda sharing about teaching learners to provide virtual care in their clinical practice. In the second part of the session, we'll briefly discuss some education research principles for multimedia teaching and share some examples of how we apply these principles into our own teaching practices. And finally, this is the exciting part, we'll also end the discussion with a discussion of future trends and areas of future development in virtual teaching and learning. Now, as Elif said, at any point, feel free to jump in with your questions or comments in the chat box. And I believe Elif will also be helping to moderate any questions that come to us. So very quickly, let's begin with some definitions and terminology. We thought it'd be helpful to review these definitions very quickly, because as we move forward in this discussion, we'll also be using this terminology to describe our virtual teaching experiences. So I know that you're likely very familiar with these terms. So quickly, synchronous versus asynchronous. Synchronous, learners and teachers are present at the same time during the learning activity. Versus asynchronous, the learning activity is not held at a specific time where everyone is present together. Online versus virtual. Online, any form of learning, any e-learning where you are connecting to electronic resources or platforms, versus virtual, which we are all engaging in here, is a synchronous connection to a learning activity or an electronic resource or an electronic platform. Now, blended and hybrid, these words have been used a bit interchangeably, and so we thought it might be helpful to very quickly talk about what each of these means. So blended and hybrid, these two words are synonymous in that you'll hear these terms being used when there's a combination of in-person and online resources in your particular learning activity. So this is not limited to being synchronous. These blended or hybrid teaching and learning opportunities can be asynchronous or synchronous. However, the word that we may not be as familiar with is this one right here, high flex. A high flex teaching and learning environment is considered a subtype of hybrid learning, where you are simultaneously in person with a group of learners, and also you have learners that are connecting virtually. And so the high flex learning environment is one that we're talking about a lot now, because now that we're resuming in-person sessions or in-person teaching, we always talk about, okay, well, what if a student can't come to class? Should we connect with them virtually? So that describes a high flex environment. All right, so for me, I've been interested in both online and virtual teaching for over a decade, and I found it exciting to see how education technology has evolved during this time. I was always one to jump in, always wanting to be the first or an early adopter to try out new education technology, whether it be with clinical simulation, developing a new learning app, or developing an app, or using new software to make my teaching more interesting and more engaging. One area of virtual teaching experience I have is with delivering our PBL classes in the School of Nursing virtually. So I started teaching virtual PBL in about 2008. And since then, I've seen the technology evolve and improve. Over the past decade, pre-COVID, I also supported faculty development with virtual PBL teaching in the school. And good thing we did that for many years, because during COVID, obviously, virtual teaching was the only way that we could deliver our PBL courses. And so fortunately, we had some faculty, a small cohort, who were already skilled in facilitating virtual PBL. During this time, I was also teaching pathophysiology in the province-wide primary healthcare nurse practitioner program. And these courses were always held virtually. And looking back now and thinking about how the technology has evolved during this time, it was really incredible how rudimentary our tools were to deliver these virtual classes. We had to make the best use of a sometimes static whiteboard where we're typing in words as we're speaking. We had very limited chat functions and little emoticons that would be, options that we can click on, and where we, as well as the learners, didn't even have the capacity to turn on our videos because of internet, bandwidth issues, etc. Fortunately, the teaching platforms evolved. And, for those of you that have been involved with virtual teaching for a while now, you'll be familiar with Blackboard, Desire to Learn, Adobe Connect, Google Chat, and now we're all quite familiar with Zoom. So generally, we have much more comfort using these virtual communication and teaching platforms to deliver our classes. And throughout all this time that I have taught and been interested in virtual teaching, I've always been interested as well in exploring the philosophical implications of teaching with technology, as well as understanding how to facilitate learner engagement and promoting learning through managing those cognitive aspects of teaching in virtual environments. So with that, I'll pass the baton over to Ilana, and she'll have much more to add to this discussion.
Thanks, Ruth. So, just building on what Ruth was saying, I have also been involved in the world of technology and education for probably in my case well over a decade. And looking at, where we came from, really just sort of what we envisioned as simple online modules, to really being able to deliver a complete course with multiple components in an online or virtual environment. And so the example that I wanted to talk about was my experience with the online undergraduate course in anatomy and physiology. So this course is traditionally taught in person. We run 2 face-to-face lectures per week. We have labs and tutorials that alternate on a bi-weekly basis for our students. And our course size is about 600 to 700 students. We draw on students from 4 different programs, including the Bachelor of Health Science program, engineering, midwifery, and nursing. And even within our tutorial and lab groups, we're still at a pretty large size of about 60 students. And we needed to look at how we were going to move the online education program in anatomy into the online environment during the pandemic. So our first experience when we had the rapid flip, which everybody had in the March 2020, proved a little bit disastrous, I think, for us and for students as well. And we really found that students took a collaborative approach, let's say, to their test taking. We had a lot of issues with running an online final exam, which some of you might have been faced with as well at that point in time. And some of that experience led to decisions we made for how we were going to deliver and assess students when we deliver the course fully online for a full academic year. So what we did, because we had the heads up about that we were going to be online, we went into it with a purposeful intention to redesign the course as if the course was only going to be delivered online, as opposed to just trying to move our content and all our materials from what we did face-to-face into the online environment. So the impact for us was that we ended up creating new recordings of all of our lecture material because we viewed those events for the students as a primary event and that it would be a much superior quality and learning experience for the students than the lecture captures that we normally did from an in-person lecture. We also wanted to try engaging with students because the lectures, they were watching it on their own time, they were asynchronously delivered. We created an Ask the Faculty session, which was a virtual session run on Zoom during their lecture time slot for students. What we encountered with that experience, while we were well-intentioned of wanting to connect and create more community and have that faculty-learner interaction, we found by and large students didn't want to show up unless we were reviewing an exam. So students in our course were very mark-driven, and so they wanted to get something out of it. We did have a small cohort that came regularly, so at least there were a few students engaging, but in terms of faculty time and student commitment to that activity, it was one that we decided we would leave out when we went into the second year of remote learning. For the labs and tutorials, because one of the missing pieces for students, and one thing they're super excited about is our in-person anatomy lab experiences, is we wanted to create something that would engage them in the online environment. So building off of our lab modules, we created interactive lab modules where we modified the labs. We tried to create some instances where they might be able to try and do a few things at home. We created videos of what they would have been doing in the lab environment, as well as self-assessment questions. And probably one of the biggest changes for us that we have kept going forward as well is we made a move from having these large groups in our labs and tutorial settings to creating smaller groups of learning communities. And so we broke the students into groups of about 10 to 12 students per TA, and each student group with the TA had their own dedicated team and channel on Microsoft Teams. And what this enabled for the students was having continuity with a particular TA that they can learn with as they move through the course, as opposed to going to and meeting with different TAs, depending on what lab they were in and depending on which tutorial station they were at. So the other piece around Microsoft Teams, it afforded us also the ability to do online office hours. And this was, I think, perhaps one of the most surprising things for us was the uptake of student engagement in the online office hours. They found that to be one of the most valuable experiences because in the Microsoft Teams chat, they were able to ask quick questions to the TAs. They were able to post images for the TAs. And that immediacy of being able to respond, because many TAs were online at the same time, maybe they were in classes, but they were jumping onto Teams messages. That created a huge connection between students and had more uptake than any type of virtual discussion platform we had had with students in the past. And for that reason, we ended up keeping the Microsoft Teams environment now that we have moved back in person. And there's a few other decisions that we made along the way, but I'm going to save that for when we start talking about some of the design decisions behind, and pass it to Amanda.
Thanks so much, Ilana. I am going to share some experience pre and post pandemic from my lens of distributed medical education, particularly in the undergraduate MD program, and then use a case example of clinical skills teaching as kind of what had to shift and what has shifted back. Virtual teaching occurred pre-pandemic really as a necessity in our distributed education network to avoid students and residents having to travel centrally for academic sessions, particularly when they were limited in the amount of time they had for the academic session or when they were very spread out in geography. At that time, the technology was centralized, usually in hospitals through a network such as OTN, and there were frequent challenges and frustrations with connectivity, with equipment, and with troubleshooting. The presenters were also usually centrally located and were often unfamiliar with the concepts of virtual engagement. So a lot of challenges were noticed in all sites in discussion, in having students ask and answer questions from remote sites. And it was uncommon to have the presenters live in distributed sites. When IT issues did occur, the presentation often continued without pause in the live setting, and there was no way for the remote locations to access the presentation after the fact. This resulted in considerable discrepancy in the learner experience, and this was often mentioned on reviews, evaluations, and even accreditation. COVID really was the great equalizer for us, where everyone was experiencing teaching through the same medium. The use of individual devices and familiar platforms really leveled the playing field for the experience of our trainees across all sites. The presenters needed to respond to a wider virtual audience, and the material needed to be available to all learners equally to mitigate technology challenges and asynchronous learning. What we've learned through this is that there are some topics and pieces of curriculum that are generally agreed to be better delivered in person. Clinical skills is one of those, and small group discussions of sensitive topics. Some of the teaching that has occurred virtually has continued in the MD program, such as the delivery of large group sessions, or the ability to join tutorials remotely when a student is well but isolating. A case study of how we transitioned to virtual teaching and the adaptations it needed is really what we did with clinical skills online. The adaptation had to happen quite quickly when learners were removed from the clinical setting at the beginning of the pandemic, but we didn't want to interrupt their learning continuity because of the rapid pace of the undergraduate medical curriculum. This was new ground for all of us. There was no validated experience or literature on what can, should, or how to do things. Clinical skills teaching is easier and better suited for virtual teaching for early learners, and more advanced learners really do have more disadvantages with this switch because of the desire to teach nuance or have the ability to correct technique after repetitive practice. We also determined fairly early on that musculoskeletal and neurologic exams were quite difficult to teach virtually because of the need for manipulation and positioning and specific maneuvers. Things such as cardiology, abdominal, or respiratory exams were easier to teach virtually, particularly for early learners, where it was just the basics of the maneuvers that we were teaching. Some topics, such as dermatology, were even found to be better delivered virtually because we could incorporate a large volume of visual material through slides, and we could ensure exposure to less common conditions than would be seen in a clinical setting. Virtual dermatology teaching is likely to continue given the resources that we've already developed. With teaching clinical skills virtually, we also had the need to assess clinical skills virtually, and that brought us to a virtual OSCE. So the OSCE is the Objective Structured Clinical Exam, which is a common tool used across multiple health professions education programs to assess clinical skills among their learners. The MD program held a virtual OSCE for 200 students from the class of 2022 in August of 2020, so still relatively early days in the pandemic, and believed at that time to be the largest virtual OSCE in North America. It was both synchronous and asynchronous stations using Simulation IQ as the platform, and we completed it all within a 6-hour window. We did consult with Merit ahead of time to ensure that it was valid from a psychometric perspective. And the exam was comprised of 3 physical exam stations, 3 history taking stations, and 4 clinical decision-making stations. Every single encounter, so every station for every student, was recorded and archived so we could go back and reassess if there were any concerns or if technology had a crash, we had a record of what had happened. The cost of the virtual OSCE was actually lower because we didn't need to feed all of the learners and standardized patients and examiners. And we did notice an increased validity in the OSCE because there were fewer assessors. We weren't the only program to use a virtual OSCE, and Speech Language Pathology held a virtual OSCE using Avenue to Learn as their platform. In their virtual OSCE, information and cases were sent to the students, and the students then had to upload videos of themselves with their responses to the case or sharing results as they would with patients. The MD program has transitioned back to in-person clinical skills and in-person OSCEs, although we continue to encourage students who are well but isolating to participate in their clinical skills sessions virtually. Other programs also had to curtail or adapt their clinical skills teaching early in the pandemic, and they've come up with strategies to mitigate the lost time or the temporary move to virtual teaching. Physiotherapy incorporated a boot camp style of delivery of focused skills, such as musculoskeletal exams, where they front-loaded both the theory and didactic teaching sessions virtually, so that when the learners then came face-to-face in person, they could focus on specific skills and getting direct feedback from their preceptors. Midwifery used a virtual delivery of some of their more straightforward skills using household objects with their students. So as they were teaching cervical dilatation, they asked students to go in the kitchen and find a variety of round objects, measure their diameter, and then practice assessing with their fingers, knowing how wide each diameter was. Midwifery also sent home some low-tech models for teaching skills such as urinary catheterization that could be used by students on their own time or as part of a synchronous learning session. There is a need to find a new balance of removing barriers to learning across a distributed network while reincorporating in-person learning because it suits some of the material better. We do need to maintain this level of accessibility for all learners who are remote from the central site and encourage the equity of experience. I'm going to move on now to talk about the teaching of virtual care as a clinical skill, because not only did our teaching have to shift quite rapidly to virtual platforms, but our care provision had to shift quite quickly to virtual platforms. And this is something that I would guess very few of us have been trained in formally in the health professions education training that we received. So beyond the consideration of using technology as a teaching platform, there's the consideration of the use of technology as a clinical care delivery platform and how we teach our learners to use this effectively. Virtual care pre-COVID was largely called telemedicine, and it included telephone and video consultations, which were done through OTN in Ontario, particularly to rural and remote areas that had limited access to specialists. Most of the experiential practice in telemedicine came from the UK and from rural and remote areas of Australia, the United States, and Canada. Minimal telehealth training existed, and it certainly was not incorporated formally into health professions curriculum. As early as 1994 to 1996, the literature exists about the evolution of virtual reality for healthcare education and delivery. The literature then evolved to discuss patient satisfaction and how to effectively interact with patients via technology, as well as the use of virtual records and patients' access to medical information online. Around 2007, articles began to emerge discussing virtual medical visits, the technologies that were available to perform these, and effective use of these technologies. And then we saw a huge leap in articles early in 2020 and since then about the remote assessment and virtual visits soon after the COVID-19 impact was felt globally. There's a high volume now of articles available exploring the adoption, the models of virtual care, and provider and patient perceptions of this care. The undergraduate and postgraduate MD programs quickly realized at the time of the pandemic that virtual care became a reality overnight, and our trainees needed to be skilled in using this method of care. We needed to begin to teach them webside manners compared to bedside manners. We had to help learners explain what they were doing with the person on the other end of the phone or the other end of the computer, why their eye gaze may be wandering, why there was the sound of typing, what their body language or engagement showed or didn't show. And we needed to figure out how to engage patients in audio-only calls or in audio and video interactions, including the use of home medical devices to provide us data that we would ordinarily gather in our clinics. The undergraduate MD program developed a curriculum of teaching virtual care as part of the virtual longitudinal clerkship. This was a short notice curriculum that was created to keep MD learners progressing through the curriculum when they were removed quite suddenly from clinical settings as a result of the early days of the pandemic. This virtual teaching included an active learning large group session presented by a general internist, a family physician, and a resident who all had been involved in virtual care. In this large group session, they were described virtual care modalities that were currently used in Ontario, the benefits, the reasons for virtual visits, the patient and provider perspectives of the visits, and the technologies that might be used. They differentiated encounters that may or may not be amenable to virtual care. They described components of effective virtual visits in primary care and specialist settings, including how to obtain electronic consent, how to document them, and what the physical exam substitutes could be in the course of a normal visit. They also described key components to presenting cases to a preceptor effectively in virtual care, and the learner experience and how to be effective as a virtual care participant. Students were prepared for these sessions ahead of time with a few resources, including the virtual care playbook that was put together in a collaboration between the College of Family Physicians, the Royal College, and the Canadian Medical Association, as well as a document prepared by the College of Family Physicians called the Supervision of Family Medicine Learners. Students also participated in virtual patient care simulation sessions to practice virtual communication skills. These sessions were held through a pre-booked video conference session. There was a new standardized patient custom case that was created called Coronavirus at Home, and standardized patients were trained in this case. The case involved the same standardized patient, but 6 different 10-minute clinical encounters about primary care cases. 2 about an adult with a medical concern, 2 about an adult with a concern about their elderly family member, and 2 about an adult with a concern about their child at home. This allowed the consideration of virtual care in multiple patient demographics, but a minimum number of SPs that needed to be specifically trained in virtual care. Each student then had the chance to interview the standardized patient virtually, while other students and faculty facilitators observed, and then the interviewer, the faculty, and the peers could provide feedback. The students were encouraged to reflect on how they will apply what was practiced in actual virtual patient care interaction. All of the material that was developed as part of this curriculum has been shared on MedPortal on a public-facing page to allow access by other institutions, because there was considerable discussion among institutions and interest in what had been created, because we were all trying to scramble with short notice. Virtual care is now much better incorporated into the practices of many primary care and specialist providers, and is likely to remain a permanent fixture as part of our practices, owing to our new familiarity with it, patient preference, and the ability to deliver some care more efficiently, as well as deliver care more widely across a geography. The incorporation of learners within this hybrid clinical setting of virtual and in-person care will become more commonplace, but it will still require deliberate consideration of the capacity, the skills, and assessment of our learners in our settings. There is ongoing faculty development that is available to consider these factors, including multiple factors by the Program for Faculty Development. I'm going to include some links in the chat to modules that are currently available on the Program for Faculty Development website, specifically related to virtual teaching, and some information about teaching clinical skills virtually. And with that, I will hand it back to Ruth. Thank you.
Great, thanks, Amanda. And I really like that webside care as well. And so as we connect webside care to webside teaching, knowing that this is a merit round, we should incorporate some of the literature around research principles and best practices or good practices in virtual teaching environments. So I think about whenever I'm preparing for any virtual teaching session, I go back to some of the first principles in the literature around cognitive load and cognitive load theory. So at the risk of talking about something that many of you might know already, I'm going to assume that some might not have heard of it, and I'll provide a very quick overview of cognitive load theory and highlight how I use these principles in my own teaching practice. Very briefly, cognitive load theory describes how and what capacity we have to process new information, First, by holding it in our limited working memory before storing and processing this information into our long-term memory for future use. Now, the three main variables that we address in cognitive load theory are intrinsic, extraneous, and germane load, because we recognize that our teaching can impact one or more of these variables. I'll also include, as Amanda was mentioning, she'll include some references. I'll also include some references at the end that provide an overview to cognitive load theory, and I'll put them in the chat box. But briefly, intrinsic load here is the subject matter on which, or the content that you're teaching, which can be inherently more or less difficult, and you manage the depth or the breadth of this content depending on where your learners are at. Extraneous load here is the stuff, the information or the extra details, the extraneous stuff or parts of your instruction that take up space in a learner's mind, but that don't actually help them learn the content that you are teaching. And finally, germane load is where instructional design, and in this case, instructional design in virtual teaching environments matter, because we want to optimize our instructional approaches to support integrating that teaching content into learners' working memory, helping them integrate new information, and creating more complex schemas that facilitate integration into long-term memory. Now, there are a variety of approaches that we can take to address each of these variables in our virtual teaching, whether it be by identifying approaches to intrinsic load or identifying an appropriate intrinsic load for a teaching session, reducing extraneous load, and also using teaching strategies to optimize germane load. However, for the sake of time, I'll just share one example and provide another article in the chat around managing cognitive load in multimedia learning. These are somewhat old school ideas, so these are not new ideas or new concepts, but these papers revisit or these papers bring up concepts that I revisit frequently whenever I'm preparing for my own teaching. And the example that I'll share with you is around our understanding of dual channel processing. And so you'll see the reason why we chose the backgrounds that we did today and the ways that we're approaching our rounds delivery is incorporating some of these principles that we have learned from the literature as well. So dual channel processing, you'll see this described also as the modality effect. So if we know that our working memory is limited, we want to optimize not only what we present to learners, but also how we present it. If we know that we have two separate channels for processing information, auditory and visual, then we can use these in complementary and synergistic ways to support germane load and increase and facilitate working memory processing. The reason I'm using this example is because the most ubiquitous teaching tool we all use is PowerPoint. And what do we find the most draining and probably the least engaging part of listening to or participating in a PowerPoint presentation? It's when we see someone who has slide after slide with a whole bunch of text on each slide. And what do we do or what do some instructors do? We might do this as well, we just simply read off every word of the slide. And so we know from a cognitive load perspective how this approach basically clogs up the auditory and visual channels with the same information. And that actually requires increased effort to process and can contribute to increasing our extraneous load, which we don't want in learning. So understanding that dual channel processing allows us to create virtual teaching experiences where we can use the visual features of a platform in a way that complements and supports whatever auditory instruction we're providing, helps to not only apply these principles of multimedia teaching and using the principles of cognitive load, but also to facilitate learning for our learners. Ilana has some more examples of how she's applied deliberate pedagogical approaches in her involvement with the undergraduate anatomy program. So I'll hand it back over to Ilana. Then she will also segue into the last part of these rounds and talk about what we see on the horizon for virtual teaching and learning.
Thanks, Ruth. So building off, I'm going to start with the slides first, because some of this isn't really new and didn't necessarily come about because all of a sudden we were virtual teaching. Many of us teach with PowerPoint slides, face-to-face lectures, online lectures. And when we were preparing for the session, we started reflecting on, what are good practice principles? What does the research say? And what are learner preferences? So even though we may intentionally design our materials in a way that we hope is going to optimize the learning for the student, what the student desires may be in conflict with that. And so one of the experiences that I frequently encountered when we were teaching anatomy in person over the years is that many students want us to put lots of information on the slides. And what's driving some of that desire is that many don't want to perhaps purchase a textbook, or they want to have lots of notes together. And we intentionally design our slides, using Mayer's multimedia principles for learning. We have, a nice graphic with labels that are, right where the component of the anatomy is that we're speaking to. And so our slides tend to be very light on text, very, kind of image focused as we're teaching anatomy. And so that's been at a bit of a tension between how we prepare materials and our learner preferences. But what this leads to is a situation also in that when we're in person, or whether we deliver lectures that are pre-recorded online, our learners like to transcribe verbatim what we're saying. And this gets into, an additional cognitive load, because they're trying to watch a presentation at the same time as trying to get down all of the words that are being said without necessarily absorbing the details. And so we haven't really, I guess, come to a happy medium, unless we start providing our learners with full transcripts of our lectures, which we don't routinely do. Now, one of the things that I think really came about, we need to be in compliant with, is the Accessibility for Ontarians with Disabilities Act. And so with the move to online and many lecturers providing pre-recorded materials, or even if they were in the live setting, having the option to have live transcription going, we now had the opportunity to increase accessibility for our learners. And so this is where, kind of taking the research, but going a little bit further and also looking at the good practice principles of what we include. And so for our recorded lectures for anatomy, we closed caption all of our recordings. But what we do is we allow the button on the recording to be toggled on or off. So learners have that option to be able to view everything that's being said, just below the slide, or they can turn that off. And so that can help to optimize cognitive load for learners, because not every learner may want to see the verbatim text of what's going on during that particular lecture. The other aspect that's come up before, and this was around, when I was talking about doing the tests before, and this isn't quite research or good practice. I'm not sure where it comes in, but I wanted to go back a little bit to about the test taking piece of things, because I touched on it before, where we have our learners doing collaborative learning or kind of collaborative test taking. And so one of the things we did when we moved online, fully online, is we employed the use of proctoring software Respondus, which was sanctioned by the university for us to use for assessing our students in our course. For us, it was a bit of a measure of, can we create a little bit of a security measure to have a bit more academic integrity, or the hopes behind that with the test taking. One of the things we didn't anticipate with that was the increased stress level that students had around the idea of having remote proctoring going on during their test taking. And we had such a high degree of stress amongst our students. We were getting frequent emails from our students around the fact that we were using proctoring software. Where this leads me into kind of this connection between research and good practice principles is really getting us to think about, how do we assess our learners in an online environment? For us in our anatomy course, we did want to have that type of multiple choice and bell ringer assessment, But in other courses, there may be opportunities to look at different ways in which learners can maybe collaboratively take a test together, or other types of assessment methods that may not induce as much stress in their learners. We did find, though, over time that learners seem to calm down and get used to the online proctoring during, because we ran multiple tests, and I think it just became, as comfort increased with it, the anxieties around it decreased. That said, when we had learners coming back into the face-to-face environment after they had been online for probably a year and a half to 2 years at that point, we had very high anxiety of our learners in the face-to-face testing environment, and many wishing we could go back online. So learner preference seems to kind of go back and forth a little bit, but I encourage you to think about every aspect of your course, whether it's the delivery of, a slide deck that you're using, whether it's the delivery of videos, whether you're doing interactive lab modules, or even doing tests or other type of assessment activities, being purposeful in the design and the expectations you have for what you want the students to do. The other aspect around the materials that we create, and I really like from the Accessibility Office, they promote the idea of the +1. So whatever material you create, having an additional option for it. So let's say for our videos, we do have perhaps the PowerPoint slides separate, maybe we have the audio separate, or we might have closed captioning added to it. So if we have a print version, maybe there is an audio recording. So the idea that we can increase accessibility for our learners. And in a small way, we've done that with our office hours in anatomy, where we've kept our virtual office hours so that students can access those hours. They have different ways in which they can engage. They can type their questions, they can speak their questions, they can create a little video clip if they want. So they have multiple ways to engage in that, which might be a little bit different than if they were in the face-to-face environment. And you wouldn't probably see a student in that environment writing out their question to their TA. So we're providing different types of accessibility for our learners in those settings. I think that's just where I was going with kind of research and a mix of good practice principles and being intentional. And one of the things that I was sharing with Ruth and Amanda is the way I think about materials that I prepare is that I think about what is the primary versus or secondary event. And so for anatomy in person, if we were lecturing live in person, I consider that to be the primary event. And if we are recording our lectures, our live lectures, those recordings are really meant for our students who might miss a class or be going back to the recording for review purposes. And we are not necessarily producing as high quality a recording or one that is optimized for learning because it wasn't necessarily the primary event that we were doing. The primary event when we're in a virtual teaching environment is the primary event. And in that case, it's being really intentional about what you are creating or delivering in that virtual environment, or if it's going to be asynchronous delivery, what that video or those materials are going to be. And so it's not simply just taking a recording from what you've done in person and putting it online, but being intentional in that recreation and recognizing that there might be faculty development work that needs to be done around that. How do you create those materials? And also the time commitment for that. Many of you are probably familiar with lots of anatomy terminology. Closed captioning does not necessarily differentiate well between a lot of anatomical terms. And there was a lot of time taken in making sure that our captions were edited accurately so that we had correct terminology for the students and they weren't getting lost if they were following along with the captioning. So those are just some of the considerations around sort of research principles, the good practice principles, and thinking about what you're doing in the different environments. And especially then thinking about what you might do if you're in a high flex environment, which Ruth was sharing earlier, and the complexities that that may involve. And so I'm going to turn to look at some of the things that are on the horizon in that we're already starting to work on these, but they're coming going forward. So one of the first ones I wanted to talk about was the development of an intelligent tutoring system for anatomy bell ringer questions. And one of, I guess, kind of the benefits that we had of running our anatomy exams online is that we ended up having an online database of questions and answers in which we could play around and experiment with. And partnering with a group that had expertise in artificial intelligence, we've been able to develop a system where through natural language processing using decision trees, we can do an automated system to assess bell ringer questions in an online environment using the Avenue to Learn platform. And for those that may not be familiar with a bell ringer type question, it's image-based. And then we have questions for each, usually we put 3 questions per image, and those question answers are usually 1 to a few words in length. And so using this automated system, we're able to, about with 95% accuracy, mark these questions. And so this has led to a bigger development of providing students with a resource and an opportunity to test their knowledge with a data bank of online examination questions, which before we would not have had that opportunity or have kind of sparked that direction of some research. More recently, over the past number of years, we have also been exploring the use of virtual reality in anatomy education. And we are looking at a variety of different things with the virtual reality. We are looking at learning outcomes, are students learning any better about anatomical specimens, looking at, sorry, I have my phone ringing in the background, looking at how performance compares when learners are learning in the virtual environment versus learning from an anatomical specimen or model. We are also looking at user experience around using virtual reality. And in particular, this year, we're looking at user experience of implementing virtual reality in a tutorial setting. And we're also looking at different factors that may influence or impact that experience. Things like sound, cyber sickness. And so we're looking at different ways in which we can extend the learning environment for learners or be able to create a virtual environment where they can learn things that might not be as readily or as easily available for them to learn in the physical environment because they're able to peel away different layers in the physical environment, in the virtual environment if we're looking at anatomical specimens. The last 2 examples I wanted to touch on briefly are, looking at sort of different examples of online or virtual education. And so one study that I've been is kind of wrapped up now was really looking at how we communicate in the virtual environment. How do we communicate with each other in a team-based, chat-based community? And so many of our online asynchronous programs have a discussion forum component. And we piloted the use of Microsoft Teams because there had already been uptake at the university with this as a platform. Previously, there had been a lot of, I think, some challenges with the layout and some of the functionality limitations with Avenue to Learn discussion forum, that it didn't feel as natural to how we would normally chat with each other. And discussion forum posts would feel more like essays rather than a discussion. Microsoft Teams chat functions a little bit more how we would communicate with each other if we were text messaging, the ability to add reactions, the ability to tag people. And so when we piloted this during the pandemic, we found that there was actually very low uptake in the discussion forum, in the discussions. And we weren't sure if it was a matter of switching platforms or if it was a matter of the fact that our learners were healthcare professionals who had very overloaded commitments given what was happening with the pandemic. We decided to continue piloting it this year, and there has been a drastic shift in uptake of discussions with reactions happening and individuals tagging each other and sharing a number of resources. So we haven't finished the course yet. It's still in progress, but there's been a drastic difference. And so one of the things I encourage you with research, and anytime you might be piloting something, is if you're not necessarily seeing the results that you expect the first time you pilot, look at what some of the confounding factors might be, and don't abandon whether a tech may or may not be useful in a setting until you perhaps optimize what that environment might be for it. And the last one I wanted to touch on is a bit of a different environment. It's a metaverse environment where we're going to be using a virtual reality platform to create a simulated emergency room environment where we'll have different rooms created as if we were actually in an emergency room. So the waiting room, the exam rooms, and learners will be able to go in and interact with virtual patients, learn about different cases, learn about the flow of movement in an emergency room. And so we're taking the basis of a game that was created. Some of you might be familiar, Gridlocked. There's also been another virtual environment created, simulation environment created, the recess room. And so building off of those principles, creating a virtual space in which learners can safely interact with each other and learn about some of the dynamics in a hospital setting. And so that's kind of research that we're just starting to build. So that's kind of on the horizon. And so I think there's lots of great opportunities with virtual learning. And I think one of the things that really excites me is I've watched the evolution, I think, of online and virtual education over the years, is the plethora of opportunities there are. And really, at some of the core of it is we can use some basic technology and be creative with it and how we use it in our teaching and learning. And with that, I'm going to turn it back to Ruth and Elif to open up the Q&A.
Great, thanks.
Perfect.
I'll hand it to Elif.
No, perfect. Thank you very much for that. And does anyone have any questions? I didn't see any in the chat so far, but if you have, you can type it or you can just raise your hand. Anyone? Well, I think as people are thinking about it, I wanted to ask something. So, I am relatively new, to the Department of Peds in terms of, I came in February where things were already kind of settled down in terms of virtual education, and actually within the department, the residency program did some work to try to understand how to optimize virtual sort of academic half days, and some of the things they found, using Zoom was, for example, for the pediatrics residents, it was really that the poll function was actually quite important, and it made a big difference for them. It made it more interested, made it more interactive. And I was just wondering, you already touched upon some of the important aspects of how to improve the virtual delivery, but could you talk to me about some of your experiences as it relates to being able to use some of these functions in the virtual environment to optimize learning?
So I'm happy to jump in just at a high level. I think that it's very easy for the virtual teaching sessions to just become a virtual lecture, and that deliberate interactivity is something that we really need to consider. So every single opportunity we have to leverage what technology has given us and is developing is a really important way, in the same way that we would want to try and do that if we were teaching in person. So the use of polls, the use of breakout rooms, the use of embedded video clips, the use of the chat function, I think are all really important, but it takes a certain level of finesse and comfort and experience with these technologies to be able to do that. One of the risks I think we run is that we all spend so much time now online for various reasons, professionally and personally, that it's easier to tune out or easier to be distracted by everything that's going on. So there almost is a higher need to be engaging engaging and deliberate in your use of technology, if that's the medium that you're choosing to use. When you are sitting around a table in person, it's much easier with the eye contact and calling people out. It's a lot harder to do that, particularly when your class size is large in an online setting. So I think that deliberate incorporation of engagement strategies is really important. Otherwise, we could just sit in a sound booth and record all of our material and push it out online and, be done with that quite effectively. If we really want to make this interactive, that doesn't happen by accident.
Great, thank you very much. I'm looking at the chat. I think Em was asking how, Ruth, you had showed the screen, the sort of words and images on the screen. It was actually, I was going to ask that too, but now we know the answer. Please do have a look at the chat to get the answer for that. Anyone have any other questions? Jonathan asks thoughts on the metaverse and the socio-materiality implications.
I'm sort of at the beginning of my thoughts on the metaverse. First, we're trying to build it. That's the first challenge for it. I think there's a lot of opportunity to be able to interact in that space. The idea of the metaverse is not necessarily new. So it's being built on a platform that is similar to other platforms that are out there that really think about gathering, having a virtual environment in which we can go up to one another and talk with one another. And so the ability to be able to interact in that way, I think, is really interesting in the virtual environment. At this point, I see it kind of more a little bit like a game. And I think really where we're interested in evaluating is from a learning aspect, what will be the impact on the learners? And it might lead to sort of an inauthentic representation of ourselves. And I don't know that it's not going to necessarily, I wouldn't see it necessarily replacing training that would happen in a face-to-face environment, but I think it could be an adjunct to training that goes on to give kind of a high level, introduction into what is this space like that you're going to be going into, being able to maybe gain some familiarity with the environment and things that might come up. I mean, it is a simulated environment. It's not going to be exactly like the fast-paced real ER environment for learners, but I think there's an opportunity to bring people together to, from a learning perspective. I know I'm not fully answering the question. We're still kind of at the beginning. We haven't actually tested it and we're still in the build stage, but we're hoping it may be a really good learning tool and provide a just different way for learners to engage with material.
Perfect. I know we only have a minute left, but Syed had that question. What has been the experience with regards to student motivation and its proportionality to engagement?
So I'll jump in real quick. I recognize we only have a minute left and share a quick story of some research that I did about 13 years ago. And this was when these virtual teaching platforms were relatively new and not as well integrated into higher education. And the way that I was looking at measuring or somehow gathering data and information about student engagement at that time was to record each of our virtual sessions and then have a research assistant count how many times an individual would turn on their emoji as a way to respond to comments and questions. And so I was thinking back on that because we've come a long way in terms of the technology that we use. And we think sometimes that the more technology we use or the latest technology we use, and if we just throw the entire kitchen sink at students, then that's going to somehow facilitate better learning. And so the reason why we were structuring part of our discussion here around managing cognitive load and effective use of multimedia is because there is a deliberate and intentional approach that we should take as teachers to manage the technology that we use to fulfill our primary teaching objectives so that the technology doesn't take precedence over our priority teaching goals. And so how does that connect to student motivation and engagement? Well, it's putting aside the belief that more technology is necessarily better, or just that these technological tools that we have available to us will somehow then have a result in a commensurate increase in engagement and motivation as well. And so disentangling that and looking at other markers or measures of student engagement within the rich resources that we have to choose from for our teaching and learning our goals.
Perfect. Thank you very much. And thank you to our panelists for this amazing session. And thank you to the audience for joining us. And if you have, I think, if you have any other questions, feel free to, to let us know. And have a great evening.